So first of all, thank you to Beneficials for giving me the chance to deliver this lecture. So I think we are already late, so we may start our session rapidly. Actually, proteinuria, in the next 45 minutes or 50 minutes, I am going to deliver lectures, and this is the outline: introduction, importance of proteinuria detection, mechanisms of proteinuria, types of proteinuria, indications and evaluations of proteinuria, methods of measuring proteinuria, albuminuria, proteinuria categories, evaluation of patients with proteinuria, reduction of proteinuria, and conclusion. Actually, about 2400 years ago, Hippocrates noted an association between bubbles on the surface of the urine and the kidney disease. And nowadays, proteinuria is a very common finding on urine analysis, which may indicate the presence of a wide variety of medical conditions. Persistently increased protein excision is usually a marker of kidney damage. And proteinuria is a strong predictor of adverse cardiovascular and kidney events. Normal protein also contains some amounts of, normal urine contains some amounts of proteins. And most of these proteins comes from plasma protein, and rest comes from the renal tubular epithelial cells and other urogenital epithelium. So from plasma proteins, albumin is about 20%, and other 80% is transferrin, haptoglobulin, immunoglobulins, lysozymes, beta-2 microglobulins, etc. And from tubular cells, predominantly TEM-Horsfall protein or uromodulin is coming. First of all, I'm showing you some practice essentials. What is the normal protein excision in urine? It is less than 150 milligram in 24 hours and consists mostly of secreted proteins such as TEM-Horsfall proteins. The normal mean albumin excision rate is about 5 to 10 milligram per day, and when albumin excision rate is more than 30 milligram per day, it is considered abnormal. Albumin excision rate between 30 to 300 milligram per day is called moderately increased albuminuria, which was previously known as microalbuminuria. And levels greater than 300 milligram per day are called severely increased albuminuria, which previously known as macroalbuminuria. And albuminuria, if persists for more than 3 months, it is considered a chronic kidney disease. Nephrotic range proteinuria means more than 3.5 grams of proteins excreted in the urine, and which indicates the pathology is in the glomerulus. To understand the importance of proteinuria, you see that in 2020 Kidney Disease Improving Global Outcomes, Clinical Practice Guidelines for the Evaluation and Management of Chronic Kidney Disease, they included proteinuria as a component of the staging of chronic kidney disease. And it is also important to note that proteinuria, when present, lowering proteinuria has a protective effect against further loss of kidney functions. If we look at this slide, you see there is a progressive rise of proteinuria, which is associated with progressive rise of all-cause mortality. And similarly, with progressive rise of proteinuria, this is associated with increased cardiovascular mortality. In another study by Dana Fuhrman among the children, they followed up the children for about 7 years, and they showed that the more the proteinuria, the more rapid is the progression of kidney disease. This is the CKD risk heat map. CKD classification contains two components. One is eGFR, another is albumin creatinine ratio. You see, at any particular level of eGFR, say it is 45 to 59, if albumin excision rate is less than 30, the risk is moderate. If albumin excision rate is 30 to 299, the risk is high. If albumin excision rate is more than 300, the risk is very high. So it shows that there is enhancement of atherosclerotic cardiovascular disease and cardiovascular mortality risk by CKD status. But clinicians should be aware that the cause of proteinuria are diverse, and there are some causes which are associated with favorable prognosis, like orthostatic or postural proteinuria, benign persistent proteinuria, while others have more sinister implications, such as glomerular disease, multiple myeloma, etc. The types of protein excision also has importance. especially for diagnostic purpose. Say increased excision of albumin is a sensitive marker of chronic kidney disease due to diabetes, glomerular disease, and hypertension. While if there is increased excision of low molecular weight globulins, which is a sensitive marker for some types of tubulointerstitial disease. So, proteinuria detection identifies a subgroup of chronic kidney disease patients that are at increased risk of progression in terms of renal disease, in terms of cardiovascular comorbidity. Proteinuria of increasing severity is associated with a faster rate of renal function decline, regardless of baseline eGFR. An early identification of patients with significant proteinuria may prompt therapeutic interventions. Conversely, a low-risk patients will be spared the anxiety and costs associated with a potentially unnecessary FRL and consultations with nephrologist. Now, how this proteinuria causes the decline in the renal function? Whenever types of whatever renal injury there is reduced nephron mass, there is increased glomerular pressure, which causes podocyte dysfunction or podocyte loss. There is increased glomerular permeable to macromolecules, increased filtration of plasma proteins, and this excessive plasma proteins there is reabsorptions in the tubules. And during these reabsorptions, there is release of vasoactive and inflammatory proteins. So tubular cell apoptosis, monocyte infiltration, accumulation in the interstitium of extracellular matrix, all these things going on and ultimately giving rise to scarring and GFR loss. Let's see what is the filtration barrier. Actually, this is the glomerulus, this is the Bowman's urinary space, and from this glomerulus, this protein filters through this and comes to the Bowman space. This filtration barrier consists of three layers. Number one is the endothelium, the glomerular basement membrane, and the glomerular epithelial cells with in between slit diaphragm between the podocytes. There is also multiple negatively charged particles in the endothelium, basement membrane, as well as in the epithelium. And loss of these fixed negative charges has consequences leading to potential filtration of protein. So mechanism proteinuria includes either there is a defect in the glomerular filtration barrier, or there is tubular dysfunction, or both. Maintaining this glomerular filtration barrier function, the crosstalk amongst podocytes, mesenchymes, and endothelium, the three important cells of the glomerular cells, is very important, which maintains the normal filtration barrier. Damage to any one of these cells may affect the functioning of the others. Podocytes, there is changes or effacement of the food process is seen in many proteinuric stages. And mutations in the genes that codes for the proteins comprising the structure of the slit diaphragm can result in overt proteinuria. As for example, in membranous nephropathy, we can see there is anti-phospholipase 2 antibodies, which is a protein of the podocyte. Similarly, endothelial cells, there is a unique feature of the glomerular endothelial cells which contains the holes in the cells that permits passage of fluid across the glomerular capillary walls. And endothelial sulfase is a covering coat that is made up of negatively charged glycocalyx, glycosaminoglycans, proteoglycans, etc. Mesangial cell plays a very important role in the glomerular hemodynamics and immune complex clearance. And this mesangial cells produces a matrix made up of collagen, fibronectin, and proteoglycans that supports the glomerular capillaries. Glomerular basement membrane is made up of type 4 collagen, laminin, nidogen, and tactin sulfated proteoglycans and glycoproteins. And these GBMs limits the fluid movement. Changes in the proteins that makes up the GBM leading to proteinuria have been described in congenital and acquired nephrotic syndromes, say in case of Alport syndrome. Defect in proximal tubule can also give rise to proteinuria because high amounts of albumins are filtered and reabsorbed in the proximal tubule, which can process about 250 grams of albumin per day. Obviously, any dysfunction in this protein retrieval pathway would result in proteinuria. Now, how we can classify proteinuria? There are different ways to classify depending on the amount of protein, nephrotic, non-nephrotic, depending on the type of protein, albuminuria or low molecular weight proteinuria, depending on the underlying pathological damage, glomerular versus not glomerular, etc. Pathophysiologically, there are different types of proteinuria, includes glomerular proteinuria, tubular proteinuria, overflow proteinuria, or mixed proteinuria. Glomerular proteinuria can occur when there is increased glomerular hydraulic pressure, various renal diseases like diabetic glomerulosclerosis, hypertensive glomerulosclerosis, glomerular disease, etc. And when there is altered pump selectivity to the glomerular capillary wall, which can found in case of different types of glomerular disease. Similarly, tubular proteinuria, when there is decreased tubular reabsorption and catabolism of the protein. Overflow proteinuria means when there is increased plasma concentration of some proteins normally filtered by the glomerulus. In the dysproteinemia, there may be excess light chains. In acute leukemias, there may be excess lysozymes, etc. And mixed proteinuria, there are some proteinuria, say in case of light chain disease, there is overflow proteinuria. But with the deposition of light chain, there may be glomerular changes and glomerular disease, which can give rise to glomerular proteinuria. In FSGS, there may be sclerosis of the glomerulus, but as well as there is also damage to the tubules, which can give rise to mixed type of proteinuria. Glomerular proteinuria, the most important criteria is that the primary protein lost is albumin. And there are some other accompanying findings like active urine sediment, dysmorphic red blood cell casts, hypoalbuminuria, lipiduria, hyperlipidemia, edema, abnormal kidney function, hypertension, etc. And there is various causes of glomerular proteinuria. The number one is the primary glomerular disease and the secondary glomerular disease. The primary glomerular disease may be with active urinary sediment or with bland urine sediment. Primary glomerular disease with active urinary sediment includes immunoglobulin IgA nephropathy, membranous proliferative glomerulonephritis, mesangial proliferative glomerulonephritis, while those with bland urine sediment includes membranous glomerulonephritis, minimal change disease, primary focal segmental glomerulosclerosis, fibrillary glomerulonephritis, and immunotractoid glomerulonephritis. Similarly, secondary glomerular disease may be also with active urine sediment and with bland urine sediment. Those secondary glomerular disease with active urine sediments includes anti-GBM disease, renal vasculitis, lupus nephritis, cryoglobulinemia-associated glomerulonephritis, bacterial endocarditis, IgA vasculitis, post-infectious glomerulonephritis, etc. And those with bland urine sediment usually includes diabetic nephropathy, amyloidosis, hypertensive nephrosclerosis, light chain disease, secondary focal glomerulosclerosis, etc. Tubular proteinuria is characterized by low molecular weight proteins, generally below 2,000 to 25,000 daltons, such as beta-2 microglobulin. Under normal conditions, these proteins are completely reabsorbed in the proximal tubule. The amount of proteinuria in tubular proteinuria is never more than 2 grams per day. Usually, it is less than 2 grams per day. And as the dipstick detects only albumin, so dipstick test is always negative in case of tubular proteinuria. And causes of tubular proteinuria includes acute interstitial nephritis, immunosuppressive agents, analgesics, cryoglobulinemia, Sjogren's syndrome, etc. I'm taken one slide as post-transplant proteinuria because there are now lots of patients transplanting kidneys in our country, and we have to follow up to these patients. Post-transplant proteinuria occurs in about 40% of kidney transplant recipients. Typically, proteinuria from the native kidney dramatically falls after transplant. But if after transplantation it is found that the proteinuria remains at the level comparable with before transplantation, it is a sign of damage to the transplant kidney. The common causes of post-transplant proteinuria includes drug toxicity, rejection, transplant glomerulopathy, and tubulointerstitial fibrosis, tubular atrophy, etc. Proteinuria pregnancy is another important aspect, but I am not going to discuss in detail about these topics. In pregnancy, we must know that urinary protein excision normally increases substantially. Hence, urinary protein excision is considered abnormal in pregnant people when it exceeds 300 milligrams per day. And proteinuria pregnancy may occur is a common feature, cardinal feature of preeclampsia. It can be due to primary kidney disease. It can be due to secondary to systemic disorders like diabetes, primary hypertension, etc. And 20 to 25% of pregnant people with chronic hypertension, diabetes mellitus, or chronic kidney disease may develop superimposed preeclampsia. So it is important for the clinicians caring for a pregnant lady to understand how to identify proteinuria and how to determine whether preeclampsia or kidney disease is the cause of this proteinuria. Overflow proteinuria is most commonly associated with the increased production of abnormal low molecular weight protein, and that exceeds the reabsorption capacity of the proximal tubule. These low molecular proteins can be toxic to the tubules and can cause acute kidney injury. Paraprotein deposition can also induce glomerulopathy, leading to the additional loss of albumin from and more profound proteinuria. Another way you can classify proteinuria as isolated proteinuria, transient proteinuria, post-choroidal proteinuria, or persistent proteinuria. Isolated proteinuria means there is proteinuria, but there is no abnormality in the urinary sediment, including hematuria. There is GFR is normal. Patient is neither hypertensive nor diabetic. The patient has no edema, no hypoalbuminemia. That is, the serological markers of systemic disease are absent, and protein excision is always less than 3.5 gram per day. This is called isolated proteinuria. And transient proteinuria means if we do a test and find a proteinuria is positive, but with repeated qualitative tests, it is no longer positive for proteinuria in absence of any form of treatment. Post-choroidal proteinuria, there is increased protein excisions in the upright positions, but normal protein excision in the supine position. And persistent proteinuria is the positive tests in repeated qualitative tests. Transient proteinuria is diagnosed if after a positive test, a repeat qualitative test is no longer positive. And this transient proteinuria can occur in cases of fever, exercise, congestive cardiac failure, or with symptomatic urinary tract infections, etc. Orthostatic proteinuria is characterized by increased protein excision in the upright position, but normal protein excision when the patient is supine. And the total protein excision is usually less than 1 gram per day. The mechanism by which orthostatic proteinuria occurs is unclear, but neurohumoral activation and altered glomerular hemodynamics may be important. So in any patients younger than 30 years who have isolated proteinuria that does not resolve with repeated testing, orthostatic proteinuria should be excluded. To identify orthostatic proteinuria, we have to take two types of samples, an upright collection and then recumbent collections. And the protein excision is quantified on both samples. The patient has orthostatic proteinuria, upright collections will be abnormal, and recumbent collections will be normal. What are the indications of urinary protein detection? The most important is the newly discovered cases of chronic kidney disease, newly discovered hematuria, newly diagnosed hypertension, newly diagnosed or any diagnosed diabetes mellitus, suspected preeclampsia, unexplained edema, superimposed heart failure, suspected multisystem disease, systemic vasculitis, and as a part of regular health checkup. How we can detect and measure proteinuria? There are some semi-quantitative methods like dipstick analysis and precipitation methods like sulfosalicylic acid or heat and acidic tests. There are other methods, so dye binding methods, chemical methods, immunological methods. These immunological methods are mostly important to identify the types of proteinuria, which includes radial immunodiffusion, electrophoresis, immunoturbidometry, nephelometry, immunoassays for specific proteins, etc. First of all, dipstick analysis is a part of our physical examination of the patient, and we can carry out this test in our office or chamber. But this dipstick analysis, this dipstick primarily detects albumin, so it indicates glomerular proteinuria. So if the patient has tubular proteinuria or overflow proteinuria, this may not be detected by this dipstick. The dipstick is very specific but not sensitive to low levels of albumin excretion. So sometimes microalbuminuria, that is moderately increased albuminuria, may be missed by this dipstick test. A dipstick urinalysis may be falsely positive when urine is alkaline, highly concentrated urine, there is gross hematuria, the presence of mucus, pus, semen, or vaginal secretions, In the presence of penicillin, sulfonamide or tolbutamide, quaternary ammonium compounds, detergents and disinfectants. And false negative results may occur when urinary proteins are non-albumin or low molecular weight proteins, dilute urine and high salt concentration. The next important test is the sulfosalicylic acid test. It is a turbidometric test. We used a few milliliters of freshly voided urine, centrifuged urine, and an equal amount of 3% sulfosalicylic acid. Turbidity will results from protein concentration as low as 4 milligram per deciliter. So this test detects all types of proteins, not just albumin, and includes also benzoate proteins. False positive results may occur when patient is taking penicillin or sulfonamide within 3 days of administration of radiographic dyes. But a false negative results can also occur if the urine is highly alkaline or if the urine is very dilute. We can use sulfosality as a semi-quantitative test. If it is 0, then there is no turbidity, it is 0 milligram per dl. If it is stress, that is 1 to 10 milligram per dl, 1 plus 15 to 30 milligram per dl. Similarly, 2 plus 40 to 100 milligram per dl, 3 plus 150 to 300 milligram per dl, similarly. So this is a semi-quantitative test, not a quantitative test. Now the question is which one we should prefer, dipstick or laboratory? There are various guidelines, but no guidelines gives any concrete conception that which one should be preferred. Say in case of Kadogi guidelines, they said if appropriate, they should undergo periodic repeat evaluation. Kerry guidelines says don't use dipstick. NICE guidelines says don't use dipstick. Science says dipstick cannot be reliably used. That means we can use dipstick initially, but it is better to confirm it by sulfosalicylic acid test. After identification of the proteinuria, it is most important to quantify the degree or amount of protein in the excision, because in most benign forms of isolated proteinuria, which excrete usually less than 1 to 2 grams per day, the degree of proteinuria is prognostically important in patients with primary and secondary glomerular disease. Higher the degree of proteinuria, it is associated with more rapid progression. And the degree of proteinuria can also be used as to monitor the response to therapy. The gold standard of the quantitative analysis is by collecting 24-hour urine specimens. And an alternative is the spot urine protein creatinine ratio and spot urine albumin to creatinine ratio determined in a random urine specimen. Fortunately, the urine protein creatinine ratio is about the same numerically as the number of grams of proteins excreted in the urine. That means if the urine protein creatinine ratio is 0.2, it is equivalent to 0.2 grams of proteins in the 24-hour urine collection. If it is 3.5, it is equivalent to more than 3.5 grams of proteins in the urinary 24-hour urine collection. So the gold standard of quantification is 24-hour urine collection. The normal amount of protein in 24-hour urine collection is less than 150 milligram per day in non-pregnant population. The 24-hour urine collection is performed by voiding upon waking and then collecting all the urine on subsequent voids until the first void of the next day. The bottles may be kept in normal room temperature for a day or two. No preservatives are needed. The disadvantage of this 24-hour urine collection method is that the collection method is very cumbersome for ambulatory patients, and there is high rates of inaccurate and incomplete collection. Protein excision rates can vary significantly from day to day, but still it remains the gold standard of a properly collected 24-hour urinary specimen for the evaluation of proteinuria. There are various reasons of diagnostic inaccuracy: incomplete collection, incorrect collection time, inclusion of 2 first morning samples, incomplete emptying of the bladder, etc. The next is the spot urine protein to creatinine ratio and protein albumin to creatinine ratio, an alternative. And this is determined in a random urine specimen while the person carries his normal activity. The urine protein creatinine ratio is preferred method for the quantification of proteinuria in the non-pregnant population because of its high accuracy, reproducibility, and convenience. In a patient, if we find significant proteinuria, or the clinical situation is suspicious for significant proteinuria, a 24-hour urine collection should be done. The spot urine albumin protein creatinine ratio can be used to follow up of the patient. If the ratio shows a significant increase, it should again be confirmed by 24 hours urine protein collection. So in an unexplained proteinuria is an incidental finding on a reagent strip. Serum creatinine, eGFR, and albumin creatinine ratio should be determined to check for chronic kidney disease. Now, which one should be preferable? Is it albumin creatinine ratio or is it the protein creatinine ratio? Actually, albuminuria screening for CKD is generally recommended for individuals with diabetic mellitus. In diabetic mellitus, always we perform albumin creatinine ratio because the bulk of published evidence linking screening or treatments of the diabetic patient is been centered on albuminuria testing. The individuals who do not have diabetes, it is not yet established whether dipstick protein or albumin should be tested. While some guidelines favors albuminuria in diabetics and protein creatinine ratio in non-diabetics. What are the advantages of using this spot urine, untimed urine and ratio? The advantage is the collection method is very simple, the collection is easier, and the urinary concentration or dilution does not affect its value as the PCR compares urinary protein concentrations with urinary creatinine concentration. The limitation of urinary protein creatinine ratio and urine albumin creatinine ratio is, it is a ratio. So there is a denominator which is urinary creatinine. So in a very bulky person with large muscle mass, there is higher amount of creatinine excisions, which can underestimate the proteinuria. While in a cachectic person or in a person with amputated limb with small muscle mass, in which the creatinine excision may be much lower and which may overestimate the proteinuria. On the other hand, diurnal variation is another important. Say, if we measure protein creatinine ratio or albumin creatinine ratio in a morning urine sample, the urine proteinuria may be less. And if we do in a evening sample after ambulatory or working, then this may be higher. So if we compare the proteinuria in a patient, we must collect the urine in a specific time in every collection. Say, one time we do it in the morning specimen, another time do it in the evening specimen, then the result may be due to diurnal variation. Result may vary due to diurnal variations. Again, which one we should prefer, albuminuria or proteinuria? There is no clear-cut consensus. PCR for non-diabetics, carry guidelines is PCR for non-diabetics, ACR for diabetics or high ethnic risks. Kadoki says albuminuria preferred to proteinuria except in non-diabetic children. NICE guideline says use ACR in preference to PCR for all patients. The science says PCR for non-diabetics, ACR for diabetics. And finally, the KDIGO says albuminuria preferred to proteinuria. So we can use either albumin creatinine ratio or protein creatinine ratio, but mostly we prefer albumin creatinine ratio in diabetic patients. The next question is which one? Is it the timed collection or is it the spot urine? Again, the guidelines do not give any specific indications. They say that ACR or PCR on the first morning were preferred but randomly acceptable. RACGP, the Royal Australian College of General Practitioners, there is no recommendations. Kadogi, ACR or PCR, first morning urine specimen preferred but random sample is also acceptable. NICE guideline, ACR preferred in the first morning sample, etc. Now come to the categories of albuminuria or proteinuria. There are three important categories, A1, A2, and A3. A1 means normal or mildly increased proteinuria, albuminuria. A2 means moderately increased proteinuria, which was previously known as microalbuminuria. And A3 is severely increased proteinuria, which was previously known as macroalbuminuria. So if we do albumin excision rate, then less than 30 is A1, 30 to 300 milligram per 24 hours is A2, and more than 300 milligram per 24 hours is A3. If we do protein excision rate, then it is less than 150 milligram per 24 hours is A1, 150 to 500 is A2, and more than 500 is A3. If we use the ratios, say albumin creatinine ratio, usually we do the milligram per gram, then less than 30 is a 1, 30 to 300 is a 2, and more than 300 is a 3. Similarly, if we use protein creatinine ratio, then milligram to gram, less than 150, 150 to 500, and more than 500 is a 3. Now, if a patient is found to be proteinuric, how we can assess the patients? Again, the golden rule is we have to take a complete medical history, a review of symptoms, systems, and physical examinations. The patient should be questioned about to determine whether any elements of medical history suggest a systemic disease process like diabetes, malignancy, systemic autoimmune disease, about any history of any previous kidney disease. Any family history of renal disease might also be present, or any recent upper respiratory infections, gross hematuria, changes in the urine output, etc. Drug is a very important cause of proteinuria. So all drugs taken by the patient should be thoroughly reviewed. Several medications can result in proteinuria. For example, non-steroidal anti-inflammatory agents, gold, penicillamine, etc., etc. And results of past laboratory studies, if available, should also be reviewed to determine whether the proteinuria is of recent or old. Physical examination, actually, minor proteinuria physical examination may indicate the presence of any systemic disease or not. But when the proteinuria is higher, say in case of nephrotic syndrome, we have to assess intravascular volume, examination of jugular venous pressure, erect and supine pulse and blood pressure, and heart sounds. Assess the extravascular volume status. Look for edema, massive weight gain due to fluid. Patients may have decreased breath sound due to pleural effusions. And we have to examine the patients for signs, symptoms of any systemic disease like retinopathy in diabetes, rash, joint swelling, deformity, stigmata, chronic liver disease, organomegaly, lymphadenopathy, cardiac murmurs, etc. And if a patient is nephrotic and heavy proteinuria, then we have to look for complications like venous thrombosis, peritonitis, etc. The laboratory investigations, in the most and important one is the urine examinations. Then we can do fasting blood sugar, erythrocyte sedimentation rates, hemoglobin, hematocrit, or both, serum albumin and lipid levels, serum electrolytes, anti-streptolysin O, C3, C4, for infection screening, HIV, BDRL, hepatitis B hepatitis serologic tests, serum and urine protein electrophoresis, serum urate, renal ultrasonography can be done, which can provide evidences of structural renal disease or about kidney size or about any chronic kidney disease. Chest radiographs may show some forms of systemic diseases like sarcoidosis. Now come to the interpretation of the microscopic examination of urine. The urine can give us various clues to about the diagnosis in proteinuria. Fatty casts, free fats, or oval fats may indicate nephrotic range proteinuria. Leukocyte casts, and bacteria, they may indicate urinary tract infections. Leukocyte casts without bacteria may indicate renal interstitial disease. Normal shaped erythrocytes suggestive of lower urinary tract lesions, while dysmorphic RBC or erythrocyte casts indicates glomerular involvement. Waxy, granular, and cellular casts or broadcast advanced chronic renal disease. Eosinophiliuria may suggest drug-induced acute interstitial nephritis, and hyaline cast is suggestive of some forms of dehydration, etc. Finally, in some cases, we have to go for kidney biopsy in adult patients with persistent proteinuria about 1 gram per day, because the diagnostic and prognostic information yielded is likely to guide the choice of the specific therapy. In children, most of the nephrotic syndromes are due to steroid-sensitive minimal change disease. So the clinicians reasonably assume this to be the diagnosis, give a trial of therapy, and reserves biopsy for only those unresponsive cases. If a patient is having isolated proteinuria and less than 1 gram per day, actually we do not go for biopsy, but we have to follow up these patients. And if the patient there is progressive increase in proteinuria or progressive decline in renal function or patient develop hypertension, then we can go for biopsy. So in summary of this physical examination, you can see that we should have to take an history, physical examination, and urine analysis and sediment examinations. If everything is normal, then repeat the qualitative test. If it is positive, then it may be a persistent proteinuria. And if persistent proteinuria, we have to exclude whether it is orthostatic proteinuria or not. If it is not an orthostatic proteinuria, reevaluate the patient periodically. On the other hand, if there is abnormalities in the history, physical examination, etc., then we have to quantify the protein. If the protein is more than 3 grams per day, that is nephrotic range protein, it is definitely glomerular involvement. So we should evaluate for glomerular disease. But if it is less than 3 grams per day, then we have to go for urine protein electrophoresis. If it is found that it is mostly albumin, then again we should go for evaluation of the glomerular disease. But if it is not albumin, other low molecular weight proteins, then we have to go for monoclonal light chains. If it is positive, evaluate for myeloma. If it is negative, then heterogeneous low molecular weight proteins, then evaluate for tubulointerstitial disease. Now, if proteinuria is found, is there any benefit by reduction of this proteinuria by any means? As many experimental evidence supports the crucial role of proteinuria in accelerating kidney disease progression, including tubular chemokines expressions and complement activations. The extent of proteinuria is widely recognized as a marker of severity of chronic kidney disease and as a predictor of future decline in glomerular filtration rate. A reduction in proteinuria invariably translates into protection about renal function decline and also cardiovascular events. So how we can reduce proteinuria? There are medical managements of proteinuria as the following components: non-specific treatment, treatment that is applicable irrespective of the underlying cause, assuming that the patient has no contraindication to the therapy. And specific treatment depends on the underlying renal or non-renal cause. Say if it is a lupus nephritis, we have to treat it. If it is a membranous nephritis, we have to treat it. Referral to nephrologist is indicated in any patients when the proteinuria is progressively increasing and there is worsening of the kidney functions. So non-specific management to reduce proteinuria includes normalization of the blood pressure, dietary manipulations, and some pharmacologic interventions. Normalization of systemic blood pressure in a patient with hypertension should result in reduction of the intraglomerular pressure and a fall in albuminuria. And angiotensin converting enzyme inhibitors and angiotensin receptor blockers are considered as first-line therapy if there is no contraindication to these drugs. Dietary manipulation includes mainly dietary protein restriction and dietary sodium restriction. Protein restrictions may slow the rate of deterioration of glomerular filtration rate in patients with glomerular disease, including diabetic nephropathy. And the presumed mechanism is reduction in intraglomerular pressure. But there is concern that if we do protein restriction, it may give rise to protein malnutrition. So most nephrologists in nephrotic syndrome recommended no protein restrictions or only mild protein restrictions, including 0.8 to 1 gram per kg per day. Glomerular capillary pressure can increase in the presence of high sodium intake. Bester and their colleagues found that for non-diabetic patients with chronic kidney disease, high dietary salt appeared to blunt the antiproteinuric effects of ACE inhibitors therapy and increased risk of end-stage renal disease independent of blood pressure control. Pharmacological therapy includes the number one is ACE inhibitors or ARBs, mineralocorticoid receptor antagonists, SGLT2 inhibitors, calcium channel blockers, endothelin antagonists, and vitamin D. ACE inhibitors, actually the degree of proteinuria depends on the integrity, charge, and size selectivity of the glomerular capillary wall and the intraglomerular pressure. And this intraglomerular pressure is maintained by the efferent arteriole and the efferent arteriole. ACE inhibitors and ARB reduces the intraglomerular pressure by dilating the efferent arteriole. There are other renoprotective properties of these drugs. They reduce the breakdown of bradykinin, which is an efferent arteriolar vasodilator, restores the size and charge selectivity of the glomerular capillary walls, and they reduce production of cytokines that promotes glomerulosclerosis and fibrosis, such as transforming growth factor beta. Normotensive patients with proteinuria also can be given ACE inhibitors because low doses usually are well tolerated and do not cause symptomatic hypotension. This is a cartoon which shows the mechanism of ACE inhibitors and ARBs in reducing the interglomerular pressure. You see this interglomerular pressure is increased. Then if we start ACE inhibitors therapy, they causes dilatations of the efferent arteriole and which reduces the interglomerular pressure. The patients started with ACE inhibitors therapy if they develop some adverse effects. So if started with ACE inhibitors, develop some adverse effect, they can be changed to angiotensin receptor blockers. The development of angioedema, which is due to increased bradykinin levels, may accompany the use of ACE inhibitors. So warrants cessation of treatment and substitution of ARB. Patients who experience mild hyperkalemia should receive dietary counseling about reduction of potassium level. But those with significant hyperkalemia should have medications stopped immediately and discontinued, at least temporarily, and should be treated with potassium binding agents. The next important drug nowadays is the mineralocorticoid receptor antagonists. Mineralocorticoid receptor antagonist has anti-fibrotic effects, anti-inflammatory effects on the kidneys and other target organs like hearts and vessels. There are significant side effects associated with first generation of mineralocorticoid receptor antagonist spironolactone or second generation eplerenone. There are now newer mineralocorticoid receptor antagonists with a relatively low risk of hyperkalemia like finerenone, eplerenone, esaxerenone, etc. The first generation and second generation are the steroidal mineralocorticoid receptor antagonists. They have high potency. Spironolactone is highly potent, but eplerenone is less potent. Spironolactone is low selectivity. That is, it works both in the heart, kidney, and other tissues. Eplerenone also moderate selectivity and low potency, but finerenone is high potency and high selectivity. So there is less chance of development of hyperkalemia. When treatment with ACE inhibitors and ARB does not adequately control proteinuria, further reduction in proteinuria can be achieved by adding mineralocorticoid receptor antagonists. Eplerenone spironolactone is associated with 3 to 8-fold increase in high risk hyperkalemia, and finerenone, a non-steroidal MRA, produces less hyperkalemia. This is a trial published in Clinical Journal of American Society of Nephrology. That is esaxerenone, a type of non-steroidal mineralocorticoid receptor blocker in type 2 diabetes with microalbuminuria. All these patients receives RAS inhibitors. eGFR is more than 30. Urinary protein excision rate is 45 to 300. They uses 3 doses, 1.25 milligram per day, 2.5 milligram per day, 5 milligram per day. This shows that urine albumin creatinine ratio is reduced by 12% in 1.25 milligram per day, reduced by 21% in both 2.5 milligram and 5 milligram per day. But the hyperkalemia is most prominent where the patient uses 5 milligram per day. So they concluded adding esaxerenone at 1.25, 2.5, and 5 milligram per day for 12 weeks to an ongoing RAS inhibitor significantly reduces urine albumin creatinine ratio in type 2 diabetes mellitus patients with microalbuminuria. The next important nowadays is the SGLT2 inhibitors. Also, they are used initially as anti-diabetics. Now they have multiple functions. This is a study which shows changes in the albuminuria. Canagliflozin predicts kidney and cardiovascular outcomes. They showed that patients with eGFR 30 to 90, urine albumin creatinine ratio 300 to 5,000. They uses canagliflozin versus placebo. This shows in the canagliflozin group there is 31% reduction of albuminuria at weeks 26. And there is some regression of albuminuria stages. That is, if it is severe albuminuria, it comes to moderately increased albuminuria. Moderately increased albuminuria comes down to normal albuminuria. And finally, there is 30% reduction of albuminuria is associated with reduction of kidney outcome, reduction of major adverse cardiac events, heart failure, cardiovascular death, etc. Then there is also some trials with use of both mineralocorticoid receptor antagonists and SGLT2 combination. In the fidelidecade trial, they uses finerenone with or without SGLT2 inhibitors. They found this urine albumin creatinine reduction in the no SGLT2 group is 32%, and in the SGLT2 group is 25%, which is not significantly different. But the patients with SGLT2 inhibitors had a fewer hyperkalemic events. So if we add SGLT2 inhibitors with mineralocorticoid receptors, there is some reduction of proteinuria, which is not that much significant, but the hyperkalemic events is less. This is another study which shows albumin-lowering effects of dapagliflozin, iplerenone, and their combination. Dapagliflozin and iplerenone, this shows that urinary albumin creatinine ratio with only dapagliflozin reduced by 19%, while with iplerenone it is reduced by 33%. And when there is combination of iplerenone and dapagliflozin, it is reduced by 53%. But the hyperkalemia is highest in the iplerenone group, lowest in the dapagliflozin group, and it is also in between in the dapagliflozin plus iplerenone group. So as this iplerenone is a newly drug, I am showing you the when should we prescribe iplerenone. If the serum potassium is less than 5 milligram, if the EGFR is less than 60, we have to give 10 milligram once daily. If the EGFR is more than 60, we have to give 20 milligram per day. Then calcium channel blocker. There are two types of calcium channel blocker: non-dihydropyridine calcium channel blockers and dihydropyridine calcium channel. Non-dihydropyridine, that is diltiazem parapamil. They have shown to decrease proteinuria greater than dihydropyridine calcium channel blockers. Why the difference between these two groups? Because the dihydropyridine calcium channel blockers affects only on the afferent arteriole. It causes dilatation of the afferent arteriole, while the non-dihydropyridine calcium channel blockers affects both afferent and efferent arteriole. Endothelin antagonists. So there is renal inflammation and fibrosis has been associated with endothelin activation. And endothelin receptor activation leads to vasoconstriction and of the vascular smooth muscles. So endothelin A blockade leads to dilatation of the glomerular capillaries, decreasing the permeability of albumin. A trial of an experimental endothelin A selective antagonist, they uses ebocentin, but this trial was discontinued because there is fluid retention and heart failure exacerbations. Another with ataracentin, another examples of ETA antagonist with better adverse effect profile than ebocentin has also been shown to reduce proteinuria. Finally, vitamin D. In animal studies, it has been shown that the vitamin D decreases inflammatory mediators, may act as immunosuppressive agents, and may play a role in the down-regulating prorenin gene expression. So a randomized control trial showed a reduction in proteinuria about 20% in diabetic patients with pericalcitriol. And a similar conclusion was reached by a systematic review by Borst et al., which found that treatment with active vitamin D reduced proteinuria even in the setting of RAS blockade in most patients. So, Mr. Chairman, in conclusion, persistently increasing proteinuric excision is usually a marker of kidney damage. Testing urine samples for the presence of protein is an essential part of the identification of kidney disease. The excision of specific types of protein like albumin or low molecular weight protein depends on the type of kidney disease that is present. Proteinuria detection identifies a subgroup of kidney disease that are at all risk of progression, both in terms of renal disease and in terms of cardiovascular mortality. The standard urine dipsticks insensitive to non-albumin proteins. The sulfosalicylic acid test qualitatively screens for proteinuria and detects all types of proteins, not just albumin. Determination of the degree of protein excision is central part of the evaluation of patients with proteinuria. And quantitative assessment of proteinuria can also be done with 24 hours urine protein collection or with spot urine protein or urine albumin creatinine ratio. A complete medical history review of systems, physical examination is essential to assess the patients, and macroscopic examination of the urine is very much helpful in the identification of the causes of proteinuria. Hematological and various serological tests are needed. Kidney biopsy may be needed in some cases. Medical management of proteinuria may be non-specific and specific, and non-specific treatments may include control of blood pressure, dietary manipulation, and pharmacological therapy. Thank you all for your patient hearing.